I'd just like to say thanks a lot for coming along. We weren't sure, as I mentioned a few minutes ago, who was going to turn up and who wasn't. The person I was talking to a couple of minutes ago, Manuel, did an amazing job of putting 95% of this together. And I really think it's going to be fun. What we wanted to do with this is mainly talk about radiation safety, but at the same time, we'd like to talk about some new simulation software that we're just sort of launching at the moment. Now, the software's been in use for a couple of years in some hospitals in Japan. They were sort of running a pilot study for us, and we got some great feedback. The 31 hospitals were involved in their cath labs and their interventional radiology suites. And we got some great feedback from them, ended up rebuilding a lot of it, and sort of relaunched the proper product, or not relaunched the proper product, but launched the proper product, or relaunched the whole thing. And a lot of it was to do with like what type of radiation do people need to know about in the cath lab. And I say the cath lab quite generically. I do mean the interventional radiology suite when I say cath lab. So when I used to teach radiation physics, a lot of what the course material was about was things like the weight of a proton. And I can assure you, if you talk to a group of non-radiographers or radiologists, they're not interested in the weight of a proton, generally speaking. So when we were putting this together, the course side of it had to be really practical, because we wanted this to be involved with nurses, with anesthetic technicians, with anesthetists. You know, everyone needed to know what to do in the environment, but not necessarily what was going on. So you have to, like, who cares whether it's protons or photons? If you can keep yourself safe, we thought that's what we've got to teach people. So this is the lessons we've created is a very practical side of things, and gonna talk about that a little bit later on. I've also got a couple of little videos to show you that I haven't spent a huge amount of time on. I put them together yesterday, and unfortunately for me, I'm not a videographer, and I think I had a second screen plugged in at the time, so it's a little bit off center, but I think you can get the gist, and I'll sort of narrate them. One of my plans was to do it live, but it's actually a bit jerky when you do virtual reality over a Zoom call, and I wanted to show you a slightly better environment. So as you've probably seen on the LinkedIn advertisements that most of you will have followed, we've got 3 other presenters, and I was wondering if I could get them to maybe one at a time. Dana, I believe you're going to speak a little bit first. I was wondering if you could unmute your microphone and say hello and what you do and how we
Sure.
sort of met.
Yes. So hello, I am Dana Smith, and I am an educator in the United States and the state of Pennsylvania out towards the Philadelphia area. I've been an educator now for about 10 years, but I've been a radiographer for about 20 years. For the past 3 years, I've been the program director at Montgomery County Community College, and I am the primary lecturer as well at the college, and that is where I met James. We were the first program nationwide over the United States to do virtual reality at our college and institution, and we have been using it ever since, and our students actually find it very helpful, especially in the image evaluation aspect. Our students, we found, were having a lot of trouble critiquing images and not being able to tell if they're optimal or not. So we use the virtual reality a lot for that, and just also things that they should not be doing out in clinical, they like to do in the virtual reality mode. So they really like to burn up those mannequins with the radiation. So as we talk about radiation safety this evening, so it's a pleasure to be here.
Thanks, Dana. Yeah, so you mentioned that you're burning up some of the VR mannequins with radiation. We were doing some looking into the data the other day, and one of the mannequins was getting over 2,000 x-rays a week. And I thought this would be someone we would probably need to have a discussion around at the end of the month. So like ALARA and stuff, you'd have to be very injured to be getting that sort of radiation. So thanks for that introduction. Shauna, would you be able to introduce yourself now?
Absolutely. Hi, everybody. I'm Shauna Walsh. I'm also a radiographer by background and a radiation safety officer. I worked in the cath lab for 10 years in Ireland and the UK. I joined Rampart, a radiation safety company, 2.5 years ago now, and I'm Director of Clinical Development. So my passion is making things safer for staff, for patients, not compromising on patient care, and just trying to move away from how we have done things to date with heavy lead aprons and all the rest. So thank you so much for having me, and I look forward to today's session.
Thanks, Shauna. Pleasure to have you here. Yeah, Shauna and her team have been doing a bit of work with us around radiation protection, and a lot of the stuff that they've come up with has just blown my mind, having worked in cath labs and interventional radiology suites before. And like you say, Shauna, you know, with heavy lead on, and there are better ways of doing things. And I think that's it's a big similarity between both of our companies. We both hear statements like, and it's not from anyone on this call, so I could probably skip this next couple of sentences, but you know, we both hear things like, but it's always been done another way, why should we change it now? And you feel like sort of saying, well, look, I think you've just answered your own question. But I'm usually polite enough not to give that exact answer verbatim. So our third presenter, Jason, would you be able to unmute yourself and say hello?
Hello, everyone. I'm Jason Rentmeester. I'm in Wisconsin in the United States. I'm one of the clinical educators. I just started at UW-Milwaukee in 2022. And before that, I was a manager for a health clinic, and I've been an X-ray tech for over 14 years now. And I changed the career paths. My program director had reached out to me to ask me if I wanted to be an educator, and I definitely jumped at the bit, and here I am. And the education is just such a rewarding job. I got to meet James when we started doing the virtual reality with our students. So I get to utilize that program with our students, kind of practicing all the different positions, and then going over kind of image evaluation and critique, just like Dana was mentioning earlier. So that has been a very awesome feature for our students to really grasp all of that content. So thank you for having me.
Thanks, Jason. It's great to hear that. It really does. Excuse me. We do hear a lot of those sort of stories that it's been so useful for students and stuff like that. And this isn't me being sort of, blowing our own trumpet or anything, but it is really, really lovely to hear. And for those of you who don't know me that well, I was also a radiographer for about a decade. And then I went into medical imaging lecturing for another decade. So anyone who doesn't know can probably work out roughly how old I am from here, because I never went to university as a child genius. And then about 8 years ago, I realized a lot of what we do isn't the most appropriate way of doing things. We've got sometimes unenergized machines, and we're trying to show people what to do in those environments with someone, a peer-to-peer evaluation, and we've got like someone shining a light beam diaphragm on a knee or something. And the same sort of thing turned up in the radiation safety that I used to teach, because I used to talk to both our own medical imaging students, and also for my sins, I was sent into large hospitals to give these talks alongside medical physicists and radiation safety officers. And I think it's reasonable to say that a lot of the people who we were talking to weren't particularly interested in what we had to say. They wanted to get in, get the certificate, and get out of there. And there was a lot of orthopedic surgeons, there was a lot of cardiologists, there was some anesthetists, and a lot of theater nurses. And depending on the country I was in, I was a little nomadic for a few years, but the radiation safety training had to be done at different times, like every year or every 2 years. And I would meet or usually orthopedic surgeons who would say, I did this in university 22 years ago, and since then I've just been turning up and getting the certificate. Can you give me the certificate? And I'd always try and sort of say, I think you'll be more informed if you spend the next couple of hours here. And they would invariably say, I don't care what you think. They sometimes might have rose tinted it a little, but not many of them. And they wanted to get the certificate and get out of there. And there was a huge problem with this, because it's not just the surgeons who are, if it was a complete, you are not prepared for radiation safety yourself, but you're also now putting your staff at risk and the patient at a greater risk, and that's a problem. So and again, it was a lot of this came back to like when I was designing this software, I thought, what does it need to do? It needs to show practitioners of all descriptions what's good practice and what's bad practice. And I can remember asking people in these sessions, because of course you can't see radiation, but I could ask people, when the tube is in a lateral position, where is a good place to stand? Is it the direction that the tube is pointing, or is it on the other side where the tube is? I think I got that round the right way. And of course, a lot of people would, and these were sometimes even third-year radiography students, would say, well, you definitely don't want the machine pointing at you because that's where the radiation is going. And you're like, well, if that was a gun, and I know less about guns than I know about radiation, so I'll just stick to radiation. But if that makes a lot of sense. But unfortunately, in this situation, it's counterintuitive. So the patient becomes the source. Therefore, we need to show this learner what's going on. And the way we did that was we colored the radiation. We did a number of years of Monte Carlo simulation, trying to get we had to simulate every photon in every possible position in the operating theater. Okay, that's a way of heating the environment in the office without all over winter, because you've got such huge GPUs spinning without needing to turn on the air conditioning. And then we thought, well, we better validate this because we've got some amazing data, and we thought we better validate this with a real environment. So we rented a cath lab with the same machine that we simulate, and we measured 15,000 real areas, with the tube and the drip stand. We were quite basic. We had a drip stand with 3 dosimeters on it, one based at the average eye height, the next one at the chest height, and the third one at the pelvis height. And we did 15,000 measurements of it with that drip stand in different places around the room, and also with the tubes in different positions with different collimations. And we found that we were within 2% in any position, so we were pretty happy with that. And the closer you get to the machine, the more accurate it becomes, which is actually the way you want it to be. So that was really good. And then, so when we're training with this, the session is kind of designed to be about an hour in virtual reality or on the desktop. Those of you who've used our software know that we do everything in virtual reality and on the desktop environment. And the reason for that, for those sort of newcomers, is we were 100% virtual reality, as the name suggests. It's actually far too easy in New Zealand to start a company. You can start it for $12. So I did that one afternoon, and then, but very suddenly you have to come up with a name. And this was the name I came up with because we were going to be virtual. And anyway, we were all virtual reality until February 2020, when we just had, we were getting about 50 or 60 emails a week from students around the world saying, our university has closed for the foreseeable future. Can we use your software at home? Now, that was 4 years ago, a little bit more, and we said, yes, you can. However, you're going to need virtual reality equipment. Now, 4 years ago, that was reasonably uncommon. It was also quite expensive in the middle of a degree for a university or a college to say to their students, you all need to get this. You know, you were looking at about $1,000 at the time. That's now about $300. And we have a number of colleges who put this as their course requirements. So for the next 2 or 3 years, you're going to be using virtual reality. We expect you to have this at home. It's essentially the cost of a textbook, a big textbook. But, you know, this has plummeted in the last few years. But at the time, we didn't have any of that stuff on the desktop. So we built a version that students could use on their laptops. So we then sent this out. It took us sort of 3 or 4 months to get the first version out. And then we just had the most fantastic things. For those of you who aren't in the States, there's something called, and correct me if I get this initialism wrong, the ARRT exams at the end of the year. I believe they weren't moved. So these students were saying, you know, we're off campus, we can't go down to the hospitals, and we haven't done any simulation, and yet I have these exams looming. And we were able to luckily let them have a desktop version of the software. And since then, obviously the main peak of the pandemic is over, and well, hopefully, but we've kept it going because people find it. Students find it useful to use at home in the weekends. They find it useful to use at home in the evenings. And sometimes even quite advanced students go and use this before a clinical placement or before their first job. We do see a spike in the data before those sort of times. So it's just really encouraging to see that this software is being used for lots of different purposes. We like to sort of think of it as an all-you-can-eat buffet. So look, I don't want you to have to listen to me for any longer than you have to. I'd love to, Dana, could I get you to unmute your microphone?
Sure.
Thanks. Hi. So we've had a little bit of a discussion about what might come up today. Would you be able to tell me in your own words, like a little bit about the as low as reasonably achievable principles and how you use this when you're talking to your students, how you instruct your students on how to use this during medical procedures that they do?
Yeah, sure. So we actually start off with ALARA with our students before they even begin in the program. We do that during our mandatory orientation that starts just to kind of give them a kind of get their feet wet. So we go over what ALARA is, which we all know is as low as reasonably achievable, and the 3 cardinal principles. And we hope they say it in unison by the time they finish. It's like music to my ears when they all say it together when you ask what is ALARA and what are the 3 cardinal principles. But the thing that we emphasize the most, of course, is distance and time. And as we know, shielding is kind of going a little bit on the wayside, but we are still using it. But we just don't use it as often as we used to in the past because of the lower dose with machines and our populations that are used in the clinical field and things of that nature. But we do practice a lot of distance is key, especially as a radiographer, to stay as far away from the beam as possible, especially whenever we're in the room during OR and things of that nature. So
cool. And when you say you're relaxing a bit on the shielding, is that with your patients being shielded?
Yes.
Or your
not
staff?
As,
right.
Not as radiographers, yes, as patients,
yeah.
yes.
Cool.
Essentially, the relaxing is as if a patient is going to be moving and things of that nature, and we use the shield and it's in the anatomical structures of interest. Of course, we don't want to get the shield in the way because then we have to repeat the exposure and then the patient gets double the dose as well. But we always have the radiographer use the shielding whenever they're in the room with patients, during OR procedures.
And I think there was a really interesting study in the American Journal of Rentmeester, and I think it's about 10 years old now, but it was talking about just that. It was like pelvic protection especially, and how difficult that is. And because of the reduced doses, we're better off. Sorry, I'm just going to mute a question. Sorry, Ron, someone else will answer in a second. better off trying to do it once, do it well, and the machines are giving, or we're giving through the machines, a lot less radiation than we would have done 50 years ago anyway. So yeah, thanks. So in the cath lab, Dana, how can inadequate radiation safety knowledge cause problems, especially for and this is possibly an area that you look into more because of your jurisdiction. We all think and know, and correct me if I'm wrong here, but the United States is far more litigious than most countries around the world. But are there risks from staff getting a higher doses than they need to when they're if they're you have radiographers or nurses, cardiologists in the cath lab for their entire career? Can they not prosecute, but can they come back to the hospital and say, I've got this cataracts or I've got this melanoma? And there is a lot of evidence that it was caused by excess radiation in my place of work.
I mean, there is always that chance of having that late effect of the cataracts and cancers and things of that nature. And that's why the education part needs to come in. And that's why software like this would be very helpful in those aspects as well, because if they understood where the radiation comes from and where to stand and where the dose is the most, and they can actually protect themselves and use that personal protective equipment properly, that would cause things, not using them, like your lead glasses and your thyroid shields and things of that nature. And also, like you touched on earlier, like Shauna mentioned about the lead apparel, a lot of orthopedic implications do happen because of the lead apparel being so heavy. So it is important to make sure that you're using the lighter lead and things of that nature when you are in the actual cath lab and for long cases and things of that nature. And that is something that we do teach our students as well, to just essentially make sure you're wearing lead, but wear light lead if you can, and make sure that you're standing in those proper areas. And we actually do, like you mentioned, doing those experiments, we actually have the students do those experiments in the lab and things of that nature as well, because we teach them that we could have late effects later on in life, such as cataracts and cancer and things of that nature, if we're not using those devices properly in the apparel.
And I mean, just to sort of, and it's not a straight line causation, obviously, but when we were doing our 15,000 measurements, we spoke to a couple of theater nurses in there, and one of the older nurses, she'd love that expression, but she sort of said, I wish we had this software 20 years ago, and she listed two cardiologists who had, one of them had died of thyroid cancer. Like I said, it's not a straight line graph you can draw, but a cardiologist standing where they did for a long period of time, and the other one had such bad cataracts, he had to get them treated. And you sort of think, well, this is the kind of problems we're hoping to avoid. And I've often compared this sort of software to like the secondhand smoking legislation that came out. Well, I know when I was in Ireland, it was sort of in the early 2000s, you weren't allowed to smoke in restaurants and bars and stuff like that. And that was all to protect the servers and the chefs. And then I suppose a decade or so before that, people weren't allowed to put asbestos in walls because that was, causing problems to painters. They were getting terrible lung problems. So, as we go by, decades, we gradually sort of start looking at things like, maybe that's not good to have this amount of radiation going around the room, and not safe training about it. Because if you look at most areas of health and safety in the hospital now, I mean, if you spilled a cup of coffee, someone would put a yellow sign up, or 4 yellow signs, and tape around it like there'd been a murder. And there'd be 2 janitors there within a matter of moments mopping it up and checking it was dry. But at the same time, we can go down to the operating theater and be at risk of something far more serious, and there's no yellow signs. Now, I'm not dismissing slipping on a cup of coffee and hurting your back, but they in the levels of seriousness, it is quite different. Debbie, I think you just asked a question. Dana, did you see that pop up? That was when I stopped speaking completely. I told you I'm not very good at multitasking. Do you want to answer that or wait till the end?
It doesn't matter. I can answer it now if you'd like. It doesn't make any difference.
Sure.
We do use it a lot, but we don't use it as an actual part of our program competency, only because it's in a separate room and it's not really like monitored during competency. So like we don't have an instructor in there with them, so they could take things in there and things of that nature. So right now we're just using it as assignments, and they actually are given, it's called like a lab assessment, and they're given it at the beginning of the lesson or like the content. And then before they have their test, that's whenever it's actually due that they have to take the images. And I do actually encourage them not to take optimal images, because they have to go over like what's not optimal and how they have to correct it. So that way it kind of helps them in that aspect of correcting the image as well. And then they also have to use it also for clinical image critiques as well, for those as well. And they're assigned the projections. So it's kind of how we use it right now. We were hoping to use it as a competency, but it doesn't also have all of the procedures in there as well that we use for competency. So,
okay, Dana, there was a paper published this morning in the journal Radiography by a lady called Ellie, who's been doing her PhD on. I'm going to do it a huge injustice here, who's been doing her PhD on radiography simulation in VR. It's not that, it's something far more comprehensive and impressive. But she published her first paper, and I saw she sent that to me this morning. I've known she's been doing this for quite a while, and so it was really nice to see. And it is just like that. And so in the conclusion, talks about most simulation, like if you look at a lot of surgeons who try and do simulation, they go in and they try and get everything right first time. So they want to, I'm not a surgeon, I'm going to make stuff up now. They want to cut the right bit and take out the bit they don't need and then sew it all up carefully. But her moot of her conclusion was that you want to show someone in simulation, this is a wrist that's over-rotated or under-rotated or something like that. How do you correct it? So that was what a lot of she was talking about. Dana, if I could ask you the next question, what are the specific challenges faced by the OR and CATH lab staff in adhering to radiation safety protocols?
Most of it is probably lack of education, knowledge, not being educated properly on it, because that is where it all begins and where we can be using the proper personal protective equipment and things of that nature. So lack of education, in my opinion, is where it kind of is a problem.
Believe it or not, this isn't a plant. We've got someone, we didn't put her with these questions in the audience. It's actually a really good point though, because my mum usually always gets mentioned during my teleconferences and webinars and stuff, and I'm going to do that again. She's used this simulation, and only because I wanted to show her one day that I wasn't just sitting idly all the time. And she was very impressed, and I turned the radiation on for her, and she was just, my mum's not medical, and she said, oh my goodness, I can see where I can't be, because if you follow the basic traffic light rules, red is sort of stop, don't go there. Orange, you should be kind of stopping, and green is obviously a much safer environment. And so she was able to say like, oh, this is just amazing for people who are training. And I was like, now we could all work that out. Like if the tube was always just in a PA position, anyone who'd gone through a radiography degree would be able to go, okay, I know roughly what's going on. We've got a series of concentric circles around the patient and we stay as far away as we can. But then you suddenly introduce steep angles in the cath lab or a biplanar unit, and you're like, wow. Well, the woman that did our, or the vast majority of our radiation simulation was a medical physicist, or is a medical physicist, and had an absolute brain like a planet. And she could calculate most of this stuff in her head, but if we said to her sort of like, oh, now I'm taking in the tubes in different angles, having one going in a lateral position and then one going in a steep angle, where is the safe position? And you're like, well, no one knows that. No one can do that in their head. So you add in the colors, you add in the live doses on the patient on the user, and people can sort of learn, oh, this is what I should be doing, this is what I shouldn't be doing. So thanks for that. That was really, especially about the education, because that's where I sort of think most of this stems from. We've all seen, we've all been in theaters where we've had people sort of pop in, and I'm pretty sure this is a quote. If it's not, it's very close to a quote, and it's going to sound a little bit sexist, so it's not great. And there's a lot going through my head at the moment saying maybe don't say it then. But people will say, oh, I've had my kids, so it's okay. And you're like, but you've still got eyes and a thyroid and skin and things like that. And they mean I'm just nipping through, so it's okay. And you're like, well, if you can run faster than light, that's fine, but I don't think you can. I'm just going to throw it out there, or they say, I'll stand behind someone. And you're like, well, okay, how big is this person? What are they made of? Anyway. So if I could sort of drag myself back to like stop going off on tangents. And we may have answered this, so tell me to skip it if you want to. How does continuous radiation safety education, and when I say continuous, I mean sort of on a cycle, and training contribute to the professional development and confidence of the medical staff that you'd encounter with radiological equipment?
I feel like it helps them actually be able to protect themselves and their patients and everybody else in the room if it's done all the time and they're practicing it and they're reminded and things of that nature. Because as you mentioned, there are also, when people get lax on things, they start to not follow those protocols. So the key component is to stay up on it, stay up on the newest and latest information that's out there as well regarding the personal protective equipment and the radiation and the C-arms and the equipment and all of that stuff in the room. And then that will help you become safe and stay safe in the room.
Thanks, Dana. Because there's a reason we have stuff or training done annually or biannually. And I don't know if that's every 2 years or twice a year. No one does. But you do get lax. And it's sort of, I think about, the way I drive, which is pretty terribly at the best of times, but I invariably stay below the speed limit. Occasionally I stray above it and I get a little reminder of having to pay $85 or something. And that sort of encourages me to stay below the speed limit again, which is kind of an obscure example of why we need this on a regular basis. It's not just learn to drive once and then just go for the rest of your life. Would you be able to answer what are the long-term benefits for healthcare organizations that invest in radiation safety programs?
Having lower dose for our patients, always, and they'll always be coming back. A lower dose for your staff as well, so less health implications, of course, in long term. Also, just having more knowledgeable people running your equipment and things of that nature, and having patients being safe in the environment as well.
Thanks, Dana. Yeah, I mean, this is the thing. It's impossible to get lower staff doses and not get lower patient doses. So it's something that hospitals, and this is sort of drawing a long bow, but hospitals can advertise, and the private hospitals love this sort of stuff, that their staff go through a certain amount of radiation protection training annually. Therefore, they have evidence to show that compared to, Deb, you knew that would do to me. Compared to the hospital down the road, that the average patient dose would be 16% lower in a certain type of operation. So that's, you know, it's definitely something that patients care about, especially, I think, because patients, quite rightly, they don't know what radiation does. They've seen a lot from places like Chernobyl, the movie, and the series, and they think, you know, radiation is absolutely terrible. Well, fortunately, we don't deal with that sort of level of radiation, but it's still something we need to be concerned about. So, Dana, did you want to say anything else? That's kind of all I had prepared for you. And did anyone want to ask Dana a question? I hope I'm not putting you on the spot here, Dana.
I think somebody did have a question on here, Ron, about the new technology and the impact on the reduction of radiation exposure. So one of the ways that the new technology does impact the reduction of radiation exposure is that we don't have to use as much technical factors as we used to have to do with film screens. So now we use the higher kVp and the low MAS, which then gives the patient less dose with the new equipment. So they're able to get a lower dose because of the way the equipment works. And now we also have things like the virtual grids or the smart grids and things of that nature as well. So we don't have to use as much technical factors as we would if we would use a grid. So those are all things now that technology has given us that we can give less dose to our patients, which then of course produces less scatter in the room, which then of course gives us less dose if we have to hold and things of that nature. So it's lovely. That's
brilliant. Thanks so much, Dana. And look, I really appreciate you joining this call and being one of our presenters. It was great to have your knowledge.
Thank you.
All right. So we've talked a little bit about like what radiation safety, the principles of it, understanding the types of radiation. But like I said, there's very little point because you're all, well, from what I could tell from the guest list, you're all knowledgeable about radiation, either through radiography. There's a couple of people from a theater on here. But what we'd really like is to have a good question and answer session at the end, because I think we've all got something to offer, and this can be an open forum. We've been trying to toss up different ideas about what we do and how we run this, and I think because there are so many experts on this call, it would be nice to have different people answering and have a bit more of a discussion. But before we do that, I was wondering if we could get our second presenter, who's actually going to give a short presentation. So, Shauna, welcome. Oh, you can share your screen. Brilliant.
Thank you. Okay, can everybody see my screen?
I can, but I'm just going to mute myself now because I don't want you to get the background noise.
Okay, super. So if it's okay, I'd love to show you a 2-minute video clip. It was sponsored by ORCIF, the Occupational Radiology Group for Interventional Fluoroscopy in the US. They have achieved just so much in creating a platform for radiation safety companies to share their ideas and a resource for hospital staff to make things safer. So hopefully this will play for me. Can everybody see it and hear it? Great.
Every time we step in here to save a life, we are exposing ourselves to potential harmful effects of ionizing radiation.
We are the occupation that is exposed to the highest amount of radiation. The only other occupation that even comes close is people who work in nuclear power plants.
Radiation was not a priority. I know myself didn't wear a badge for more time than I probably should admit.
The history of radiology begins with Conrad Rankin.
As soon as he developed that film, it became an international phenomenon.
Because you couldn't see it, feel it, or really be aware of it, didn't fully understand its potentially damaging effects.
Any radiation is bad, and you don't know how your body's going to respond to it, and the effects of that radiation could come out later in life.
I think I felt this radiation cannot hurt me.
I was diagnosed with breast cancer in 2021.
The most at-risk person when it comes to radiation are young females.
I am concerned that they're putting their unborn child at risk.
It is a controversial subject, not totally proven that people that have been exposed to X-rays have developed cancer.
It's just not known yet. We're doing the experiment right now. I want you to think about why the left side of the body is so important.
When you look at interventional cardiologists with brain cancer, that over 8 out of 10 of those brain cancers are going to be on the left side.
I don't think any care here. Consistently, it's 90 to 92% of all my skin cancers were on the left side of my body.
We're really limited in the data that we're relying on.
There's another type of exposure that we face. It's wearing these lead aprons. Ruptured disc, completely paralyzed.
Muscle wasting, foot drop.
My right leg was paralyzed. I couldn't walk for over a month. Yesterday was my last day in the OPL. So, no more outpatient procedures. It takes people, and these people have lives, and these people have families, and these people have a future. That passion has damaged my body to the point that now I can't even enjoy the fruits of the labor.
I would like to say we know everything is about radiation exposure and the effects on human tissue, but I don't believe we know nearly enough.
So Scatter Denial is a 6-part series. It's available actually with this QR code. A really interesting watch, very hard hitting, but I'd really recommend it to you all if you get an opportunity to watch it. So today, kind of main agenda, the X-ray evolution, a very brief journey through time, understanding the risks and a time for a change. Thank you, Dana. I think we covered some of this already, so I may skip through parts of it. So early days of X-rays, and I think a lot of us will know this, but it's difficult for us to imagine a world without X-ray now. X-ray was discovered by German physics professor William Röntgen in November 1895 during testing of electrical currents through vacuums. And Röntgen saw that the ray passed through a piece of cardboard. So he wasn't sure what it was. He called it X-ray, X being the traditional term for the unknown in the physics world. Within 2 weeks of the discovery, Röntgen had taken the first X-ray, and in famous image now, as we see here, it's of his wife's hand, and he made the announcement to the world on Christmas Day. It was largely thought to be a hoax, even by the world's most famous physicist at the time, Lord Kelvin. However, Röntgen went on to receive numerous accolades, including the very first Nobel Prize in Physics in 1901, which he donated to his university. So new diagnostic capabilities came at a cost at the time. The use of the machine did have undesirable changes to exposed tissue in some of the early adopters. An 1896 UK report described dermatitis of the hands of investigators. And the first radiation-linked death is believed to be Clarence Daly, Thomas Edison's assistant. Daly spent 90 hours per week exposing his arms to X-ray, 1,000 times stronger than what we use today. And for most of those hours, his arms were directly in the beam. Unfortunately for Daly, after a few months, he required bilateral amputation. He had really horrendous burns on his arms, and it was estimated that his absorbed dose was over 30 gray for amputation to be required. By 1904, his 39-year-old body was ravaged by metastatic skin cancer, and Daly died after 8 years of experimenting with radiation. His tragic death eventually led to a greater understanding of radiology. And it was really, I guess, unbelievable at the time that some of the risks were known, but for the love of science and to advance the technology, a lot of people did endanger their lives for the benefits that we have today. Unbelievably, and I actually only learned this very recently when I was preparing a presentation for another group, but shoe shops offered foot x-rays mostly targeted at children when they would buy a new pair of shoes. And this practice happened mostly in the US between the 1920s and 1950s. The x-ray doses were largely uncontrolled. They didn't have any professionally trained person operating the machines. And the last foot fluoroscope was taken in Boston in the 1970s. And, you know, they were very closely linked to dermatitis at the time. So is this a historic issue or a modern day concern? Well, thankfully, we had a big response from international medical organizations. Radiation protection committees were created. Radiation protection guidance was recommended and dose quantities were defined. However, the cath lab landscape is changing. Our patient profile is also changing. And we have a lot more complex stuff now going to the cath lab than we did years ago. We have high-risk procedures, obesity, an aging population, patients coming that have had extensive historical work in the cath lab, structural disease, etc. So constant vigilance is required. And as Dana mentioned earlier, really focusing on ALARA as low as reasonably achievable, time distance shielding and utilization of new technology. In 1982, the average yearly dose was 0.5 milligray. That has now gone up to 4 milligray, despite the X-ray equipment advancing. So when we think about the risks associated with radiation exposure, we can break them down to deterministic and stochastic. One of the characteristics of deterministic is the existence of the threshold dose, meaning that exposure to radiation under this level causes no effects, but exposure to radiation above this level causes effects. Radiation exposure above the threshold dose causes the death or degeneration of a large number of cells at one time, and the incidence rate increases sharply. So examples of this: radiation-induced skin burns, acute radiation syndrome, radiation sickness, cataracts, sterility, tumor necrosis. On the other hand, stochastic effects have been defined as those for which the probability increases with dose, but without a threshold. So under this assumption, the possibility that radiation exposure, even at extremely low doses, may exert some effects can never be fully eliminated. And stochastic effects include cell mutation, which can lead to a radiation-induced cancer. And I know it was mentioned earlier about radiation being invisible, and that's one of the issues with it. A lot of these radiation-induced cancers have a biological latency of over 10 years. So because we can't see it and we can't see the danger happening today, it can lure us into a false sense of security. This study is very interesting. It's likely the first study that really explores DNA changes as a result of X-ray exposure. So DNA markers were observed immediately after, and 24 hours after procedures in vascular surgeons. The green group used X-ray and the brown didn't. So we can see an acute cellular response just after exposure here in the green group. And although this does go back to the baseline, it's a really interesting insight into the sensitivity of our DNA to radiation. This study also included in vitro irradiation, which demonstrated that operators had a variable susceptibility to radiation-induced DNA damage. As we can see here in operator 3, so the pink, such individual risk profiling may improve radiation protection in the future. A really interesting company that I met with recently here in Toronto, they're called Cora. They have a radiation tablet, an antioxidant complex tablet called Halo. And it has been designed to take 2 hours before X-ray exposure in the cath lab. So really interesting concept. But back to this study, they also looked at with and without leg shielding. And it was noted that the majority of the DNA damage in the lymphocytes occurred in the non-covered leg. So once the leg had lead on it, there was very little difference between that and the team who did not use X-ray for their procedures. So brain tumor location, we did hear in scattered denial there at the ORSA video. Physicians who unfortunately have brain tumors, there is a large prevalence there to be left-sided. 86% in this particular study were left-sided brain cancers. And when we think about, cath lab safety, it's not just about the physician, it's about everybody else in the room. Radiographers, technologists, depending on what country you're in, the nurses, it's really about, trying to protect the team. In this prospective cohort study of over 90,000 technologists, they found an elevated risk of brain cancer, breast cancer, and melanoma, and a twofold increase in brain mortality was also observed. So one of the, we have a number of issues with traditional shielding, being the lead apron, incomplete coverage for one, our long bones, breast tissue for women if the lead doesn't fit correctly under the arm, eyes, brain, thyroid again if the thyroid isn't sufficiently covered by a thyroid cover. Lots of key areas are exposed. And the attenuation of the lead also greatly varies depending on the thickness of the lead. So, the lighter you go, the less protection you have, especially at those high KVs, and high likelihood of injury. So interventional staff have 7-fold increase in orthopedic issues compared to other specialties, and a 10-fold increase in spinal issues compared to the general population. Dr. Bob Foster, you may have seen him in the ORSA video. He's actually the creator of Rampart. He was an extremely fit triathlete, worked in a very high volume lab in Alabama. Unfortunately had 2 disc ruptures and required 2 lots of back surgery. He had paralysis in his leg and didn't practice for 2 years. And he designed the Rampart solution for his own use to get him back into the lab, being able to treat his patients again. But we'll look at Rampart in a moment. So in terms of behavioral things that we can do in the cath lab to reduce dose, because it really does start with the basics, as we all know. It's not just about, wheeling in a Rampart and thinking that's everything covered. It isn't. So we can do things like, we've the X-ray tube under the table. We want to raise the table height, the detector as close to the patient as possible. Inverse square low, so being very mindful about where we're standing. If we double our distance, we quarter our dose. So if we have new nurses in the cath lab, try and get them away from the head of the patient, really just increasing their distance. Reducing screening time, so avoiding heavy foot syndrome. When fellows get the most radiation when they're in that fellowship year. They get 34% more radiation than other interventionalists. And this can cause huge problems down the road for them. So even though they're learning, just being mindful that if there's no clinical benefit of them X-raying, they really shouldn't have their foot on the pedal. Minimizing fluoroscopy and cine frame rates. So at max 15 frames for cine, 4.5 for fluoroscopy. I cover a lot of the Scandinavian countries, and we have seen even less, 7.5 and 3.5. I will say it does take some time to train the eye. But it is something that maybe some physicians could consider going forward. Reducing the frame rates dramatically reduces the radiation. And using fluoro-save instead of cine, you'll have 6 to 10 times less radiation by doing that alone. So avoiding steep angles. I really like this first diagram here. It shows by increasing your LAO projection, by going closer to that 60%, you have between an 8 and 10-fold increase there in your radiation. So again, if it's not clinically required, really trying to discourage the physicians from going to those angles. Collimate area of interest, reducing your MAG. So MAG2 produces 4 times the radiation of MAG1. The utilization of intravascular imaging, so the likes of IVUS, dramatically reduces the radiation dose. Utilizing dynamic coronary roadmap for regular maintenance of the X-ray kit, QA, calibration, radiation safety training for staff, and wearing a radiation badge. So I really like live dosimetry in conjunction with monthly badges. And there's estimated to be a 70% decrease in staff dose when they have live dosimetry on, like the likes of ARRT. So when we think about, a time for change, along with the behavioral things that we can do, we also have structural/barrier technology now available to us. So we have selection of different companies there. To talk to you a little bit more about RAMPART. RAMPART is a system that is wheeled over the patient. It comprises of 1 millimeter lead equivalent acrylic panels, so double the attenuation of your mobile shield. It's a really quick setup. It probably takes 45 seconds to drape. It's 3 bags. And that's typically done by the scrub nurse as the physician is getting access. It allows unlimited C-arm views. The patient is always in view, the panel is clear, and it's very easy to remove it should you have an emergent situation. I will say for the most part worldwide, accounts tend to keep RAMPART in place. You can do CPR and shock your patient with RAMPART in place without any limitations. So in terms of our clinical evidence, and we have a huge amount, we have 2 randomized control trials, both showing 99.7 radiation attenuation, resulting in 20 times more radiation protection than traditional lead aprons and shields. And just to point out that that is lead-free with RAMPART. It is a lead-free technology, should staff wish to be lead-free, and if the country allows it. We have an independent published head-to-head trial which explores some of our competitors with the greatest radiation dose reduction. We have an independent phantom publication report which again showed superiority over standard lead aprons and shields. And we have 1,700 real-world cases now showing greater than 99% reduction in radiation dose. So one of our independent studies, it was published in JSky last year, 100 consecutive coronary and structural heart randomized cases. 3 staff members were badged in multiple locations, and head and neck showed really fantastic results compared to traditional shielding. But overall, for whole body dose, there was a 20-fold reduction in radiation to the body with RAMPART, with the team out of lead when compared to traditional shielding. So real-world data, and just to point out, this is the next slide is in microsievert, and it is using the international yearly limit of 20 millisievert or 20,000 microsievert. If we look at this in the US, our numbers are even better, but we'll take the lower limit just to be fair. So 0.2 millirem to microsievert is our average for operator 1 out of 1,700 real world procedures worldwide, 154 sites now and 671 operators. So if we take 2 microsievert as operator 1's average, and I will say the other operators were a lot less, so we're taking the highest average. If we look at 1,000 cases per year at that average, that person is on 10% of their allowable yearly limit of 20 millisievert lead-free, and that's less than background radiation that we all get by just walking around the planet, and it's less than half of what cabin crew get flying around the world. So as a company, new product development goals, We will soon have total room solutions to protect all team members, including those at the head of the table and the left side of the room. We're looking forward to, because most of our business to date has been in the cath lab, we look forward to looking at new specialties going forward, IOR, vascular and neuro, with greater procedural adaptability and flexibility being a big focus for us this year. Growing our clinical evidence and hoping that we can continue to give teams the choice to remove their lead aprons if they wish. And final slide, these are our Rampart superheroes worldwide. So no lead on when they pull off their sterile gowns. So we have Europe, we have lots of different places, US represented there, Australia. So thank you so much.
Shauna, that was excellent. Thank you very much. When I was introduced to this technology, I was sort of an immediate fan. And it was just because of what? And I was going to remind you at the end, but you did say it a couple of slides ago. It was completely lead-free. And the first time I saw it, I was just like, how amazing it must be for a cardiologist or an interventionist to have done something for 10 or 15, 20 years and then be able to walk in, do the same job and have less radiation. So that's really, really good. So thanks very much, Shauna.
Thank you. And just on that point, we do it in a very safe, controlled way. Anybody removing a lead, they need live monitoring on to ensure that, we have no gaps and that the system is fully optimized. There is a robust training process as well, didactic training with lots of different areas. So it is done in a very safe and controlled manner. So yeah, but it's amazing to be able to give people the choice if it's something they want to do.
So Jason, what role does radiation safety training play in protecting patients from unnecessary radiation exposure? And how does it align with the ALARA that you teach?
Yeah, I think the radiation safety training is vital for all students and others as well. It teaches them the importance of where to stand for a specific fluoro procedure. If you're in a cath lab, if you're in an IR room, making sure that everyone is wearing lead aprons before you start any procedures, making sure they have their thyroid shields, make sure they have their dosimeters outside their lead aprons, and making sure to distance yourself as much as you can. Obviously, that's going to reduce the dose to the staff members, and then also just making sure that you're applying those different techniques on the C-arm, whether it's using the low dose, using the pulses per second, and then just kind of keeping that image receptor or II as close as to the patient as possible. That way, it kind of reduces the amount of scatter that's being dispersed throughout the room.
Cool, thanks, Jason. And it's actually interesting. Both you and Shauna were talking about the sort of the tips of going through. And in my the second video that I've recorded, I want to show everyone what the radiation safety lessons are, and it does come up. It's about like the distance of the detector from the patient, whether you've got your lead protection on, and then in your report you get these figures. And a lot of people have said to us over the last couple of years, I only needed to see the report once, and I realized that doing it this way rather than that way, I received something like 900% less radiation to my eyes. And you're like, we're done here. Whereas without that, people are kind of like, yeah, I've been told to wear those glasses, but they're kind of clunky and uncomfortable, so I tend not to. And you're like, well, then you're getting 900% more radiation. And you're like, I'll put them on. So, Jason, how can inadequate radiation safety knowledge among cath lab staff lead to an increased legal and financial risks? And we did ask Dana something similar, so you can feel free to sort of put your own twist on that if you like.
Yeah, just to piggyback off of Dana, obviously can lead to increased cancer risk or tissue damage, as Shauna was kind of showing us with the videos of the stochastic and the non-stochastic effects. Understanding these risks and, utilizing that VR radiation safety training, it can teach everyone, where where the most sensitive body parts are, how it's being dispersed throughout that OR room, where are those green, yellow, orange, whatever color there is designated for that specific radiation. And it can kind of really educate these individuals to, stand back as far as you can, known as, the inverse square law that Shauna was showing before. As you double your distance, you're going to have a quarter of the dose to you, because the intensity of the radiation is, inversely proportional, meaning that as you stand farther back, there's going to be less radiation getting to you exponentially. Measures that can be taken to maybe avoid these risks, I would say, having these annual mandatory trainings or learning opportunities for staff, just to kind of promote that awareness, as well as any kind of friendly reminders of the importance of keeping that dose as low as reasonably achievable.
Thanks, Jason. And it's an amusing story in a way. When I worked in the cath lab, I don't know what it's like in the States, but I know in the UK and Ireland, it's supposed to be the radiographer who's in charge as soon as there's a radiation machine in the environment. But as you can imagine, with some cardiologists and orthopedic surgeons, and I often blame orthopedic surgeons for a variety of things, but I think quite rightly, that I worked with a cardiologist who was quite a good cyclist. I used to go cycling with him at the weekends and stuff, and he had no hair on his lower legs, and he maintained it was quite good for cycling because he didn't have to shave his legs. And I was like, yeah, but you know how easy it is to get a razor compared to the damage you're putting up with on your skin. That was 20 years ago. Hopefully he's now got some lead protection on his lower legs if he's still working, and if he's still cycling, and he just waxes or shaves his legs. So, Jason, why do you think that radiation safety is difficult to teach in its current way to like OR or cath lab staff? And when I say the current way, when I was doing it, I was given a course that I had to present to a bunch of theatre staff, and like I said, I often talk about, one of the things to discuss was the weight of a proton and how far an electron can travel through a bit of paper or something in a vacuum. And there was a huge power imbalance with a lot of the surgeons just saying, look, this is a waste of my time. I did this 30 years ago. Just give me the certificate and let me go. So why do you think it's so difficult to train people either on an annual or 2-yearly basis?
Yeah, personally, I think it comes down, it could be due to maybe some staffing issues. Maybe they're working on very short staff. Some of the procedures are lasting longer than the normal, which can obviously cause higher dose rates to staff as well as the patients. The other thing is, I guess it's just hard to say as far as each hospital, how they manage everything. Are they getting the necessary breaks so that, they're not standing for 10 plus hours and they're getting fatigued, and then also trying to get into that training module. So I think somehow having those little breaks to help them try to re-educate themselves, or just kind of more of a refresher than anything, I think that can help target some of those training issues.
Yeah, thanks, Jason. Because it was definitely what I experienced in when I was teaching this in the hospitals. People would say, oh, look, we're 3 theatre nurses down or something this week, so they're not coming to the training session. And you're like, oh great, will we see them next month? And they're like, no, next year now. And you're kind of like, it's less than ideal that someone, due to someone else having a cold, has to skip their radiation safety training. And that was one of the things we really had to ensure was appropriate when we were designing this software. Is, can it be done in parts? Can it be done really quickly, and yet still be far more effective than the traditional didactic training? And so, a first timer who's never used VR can go through this. The feedback we got from Japan was the whole radiation safety training would take less than an hour. And you're like, okay, so that's good. And then you sort of say, okay, well, there are 8 or 9 lessons in the environment. You can do them whenever you want. You might do 3. If you get to an operating theatre in the previous case is overrunning a bit, you can do it on your computer in the staff room while you're having a cup of coffee. And that's what a lot of people were sort of saying, now this is better than me having to go on a Saturday morning to a lecture theatre in a university up the road and do a 4-hour course on radiation safety, and then, you know, in groups of 12 be taken to the operating theatre and someone show us, because I used to have to show people an image intensifier and then turn it into different ways. And there was nothing they could do with it. They were just like, and I was like, and now it's on its side. So yeah, you want to stay away from this sort of area, but it meant nothing because you couldn't see the radiation. So you talked to me a little bit, and I'm going off script here, of course, but you did talk to me about clinicians and theatre staff hiding behind other people, and I know we discussed this earlier. What do you think causes that in practitioners to sort of jump into the situation where they go, I'm just passing through, so it's all right, this person has a lead coat on, I'll stand behind them?
Personally, I probably think it's more to do with, you know, having those light aprons on for an extended period of time. As we've seen in Shauna's video, it can really strain on the back, and that could cause, you know, further damage down the road. Luckily nowadays, they do have, you know, those anti-gravity leads at some sites to prevent some of those back problems. Obviously, that's probably more of a cost-related issue, which is why not everyone has these, but these are something that, you know, could be a game changer. That way there's, you know, not all that lead strenuous weight on their shoulders leading to back problems, but also too, it could be just due to lack of knowledge. It could be due to the fact that, you know, they really don't fully understand what these radiation exposures can do to them in the long term. They think, you know, hiding behind somebody, or they're protected, or they try to do as much distance as they can. But at the end of the day, regardless if you're standing behind somebody or you distance yourself as much as you can, you're still possibly, you know, being exposed to that radiation, which can then lead to further damaging the tissues down the road.
Thanks, Jason. And this was something that, you know, the way in education we all say you've only got to be 1 or 2 steps ahead of your students. Well, it turns out I wasn't, because I was teaching radiation safety, and when we did all this simulation, I learned a lot more about front scatter and back scatter and side scatter. And I was like, you know, so even if you are standing behind someone, because we can move our people around the room, as you'd imagine, and you know, you can put a variety of staff members, like for some reason you'd put the cardiologist at the front and then maybe the anesthetist behind them, and then say a radiographer, but they're getting obviously a less dose, but it's not zero, you know, whereas kind of what we're looking for is this holy grail of a 0 dose. So look, Jason, thanks very much. As expected, that was absolutely brilliant. Has anyone got any questions for Jason?
Hi there. I don't know if you can hear me right now.
Hi, Phil. Yeah, we can.
Awesome. Well, thanks for coordinating. This has been such an, you know, a helpful presentation from everybody. For me, just learning more about radiation safety. You know, my question is for Jason, Shauna, really everyone here. I think everybody's here because it would seem, you know, not only working to educate healthcare professionals in their own practices, but you know, there's a passion for it individually. And you know, I think one of the challenges that I've come across just in my own experience working in cath labs, EP labs, and more recently, all sorts of interventional labs is the care factor, and what really gets across to an individual working in these labs to cause them to change their behavior that they've trained and worked in for, you know, in some cases decades. You know, that's still a question that I ask myself, and wondering, you know, there's just so much great information just shared in this last hour and a half that you know, resonates with me. But how do you get across to somebody who goes to the training, gets signed off, certified, and doesn't think about it again until the next training next year and hasn't changed one bit about their approach. What is that? What's that kind of, in your own experience, where has that archetype of person, changed their mindset, and how have you been able to do it successfully?
Is there anyone who wants to take that? I do have a little answer, while anyone else might be thinking. But Phil, that was a really good point. Thank you. So, in my mind, it's a little bit of carrot and stick, and I hope that's an expression everywhere else in the world. If not, carrot means you're encouraging someone, and stick means you're punishing someone not to have done it. So, with cardiologists and everyone else going into the cath lab and the interventional radiology suite, you can have mandatory training every year. Now, in some countries, a lot of South American countries, most European countries, and 47 out of, and I'm going to say 52 states here, but I always have the disclaimer that I know that's about 50 and 2 territories or something. But there's a lot of states who follow the guidelines of the American Radiologic Society, and they need some sort of radiation safety training, and depending on where you are, it's either annually or every second year. So that's the stick. If you don't do it, you might not get your certification next year or when you go to reapply. The carrot is really showing people the benefits, and these are the benefits for your colleagues. They're going to get less radiation and probably fewer pathologies because of the less radiation. And like I said earlier, there's no straight line you can draw between them. But there's enough evidence now that we're starting to draw some pretty good causations. And the fact that I said pretty good causations means I'll be kicked out of any statistical course. But also, so for the patients, for their colleagues, for themselves, if they're able to see this relationship between good practice and bad practice, it's very encouraging, and it's usually very small changes. Like the way we set up our theaters, the staff still have to be able to operate. So you can't say, well, for this environment, I'm going to hide behind the anesthetic machine in the back of the room. It's kind of like, well, yeah, you got a very low dose, but you weren't doing your job, so you might not have, you shouldn't have been in there. So say one of the scrub nurses, they should be beside the femoral access with the table beside them, the surgical table. But for example, if they take a step to the other side of the table, they can see their pelvis dose drop dramatically. Now that's something that they can do. Or the anaesthetist to the other side of the anesthetic machine when the tube is in a lateral position pointing in one direction or the other. And you're like, with these tiny changes, I can see the difference it makes to me. And you're like, that's the carrot. That's how you're going to get people doing things. It's not saying to them, do fewer operations every year or something. Does anyone else want to chime in and say something else about that?
Yeah, I'm happy to. A great question, Phil. I would also say, data is what's going to, change people's ideas. If we show them the data, that's going to kind of spark them. And it's also what James is referring to, with those trainings. If they don't complete those trainings, it could affect their yearly annual wage incentive. So these different incentives to kind of get them to do these trainings can also inhibit them or promote them to complete these trainings. The other thing too was just showing them or having them actually see it by utilizing, a VR training like this with the radiation safety. It can kind of stick with them. Whereas if you're just reading a screen with words, yeah, you're reading it, but are you really understanding it? Whereas if you actually do something, you can actually, studies have shown if you do things, it's going to stick with you longer, and it's also going to be able to, for you to promote these educational material to others so that they're also practicing these safe radiation standards. The other thing I would just add, with the whole DAP or the dose area product, most patients are getting these doses being submitted into their electronic medical record. Down the road, how that's going to change, maybe I'd have to defer to an RSO, but I could foresee maybe something in the future having these accumulations of these milligrays doses in their chart, and then seeing if they get any pathologies in 10 years, 15 years, and then kind of tying that data all together, which is what I'm talking about with this data. It'll be interesting to see, 15, 20 years from now, how all of this can correlate together.
Thanks, Jason.
Ron, yeah. I have two quick questions. Ron here. Can you hear me?
We can indeed.
Okay. The first question is, in Ontario, Canada, we have what we call the ARRT regulations, the Healing Arts Radiation Protection legislation to do with radiation safety. Does any of our audience have any local regulations on radiation safety by the government? That's the first question. And the second question is regarding continuing education. Are there any recognized training courses that have been approved by professional bodies that would give CE credits to maintain your annual license?
Thanks, Ron. If I could open that to the wider floor. And Shauna, I know you live in Canada at the moment. You might know the answer to the first one, but you might not. So I'm not going to put you on the spot again.
Yeah, so it depends, Ron. I think, so in Canada, it's by province, usually the regulations. Some it's countrywide. So Ireland, for example, it's countrywide. And that's one of our challenges when it comes to teams potentially removing a lead apron. We have to work with the bodies within the regulations for teams to be allowed to be lead free. So we have some experience with that. Some places it's easier than others to change regulations. I'm not sure if that answers your question or not.
Yeah, I know about the HARP Act. I'm a member of the Ontario Association of Medical Radiation Technologists. So I know it is difficult to get regulations passed through the government, but I hear you. But my other question was, many of our professionals require continuing education credits. And I was a bit concerned. I'm a radiation therapist by profession, not radiographer. When you have a new resident going into a cath lab or a nurse, who is responsible for radiation safety in the hospital? Is it the radiation protection officer? And the role is to give seminars and education in radiation safety?
I can answer that one a bit, Ron. Other people might want to say something else. So we've been working with the ARRT with continuing medical education credits for this software. As you can imagine, it's not a speedy process. We've submitted some information, and it's obviously all evidence-based material. You've got to say, this is what we do, and this is how effective it is, and this is how we know. And I've mentioned to you on a number of times that I know of studies that are coming out, but we've obviously remained at arm's length during all this process, because if we get involved in the slightest, we'll taint it. And yeah, that's actually what you want with this software that can be done at sort of anywhere, anytime. It's someone to say, I need some continuing medical education credits. I need some specifically in radiation safety. So I'm going to do this hour by desktop or virtual reality and get the 3 credits or whatever it's measured in. So that's definitely something we're really keen on, but it's unfortunately not as quick as we would have liked.
Well, I'll pass that information on to the Canadian Association, and perhaps we could organize something through them.
That would be fantastic, Ron. And I know, Deb, you had something to do with CME credits in a former life. Is that right?
Yeah, a little bit. Yeah, when I worked, basically every company I've worked for, including Varian, both ASRT for radiation therapist, radiologic technologist, as well as medical dosimetrist as well. They all have their, I'll have their flavors, but once you know what to, what hoops to step through, so we can revisit that. And if I can help with that, I certainly want to.
That would be great. I should just briefly mention while Deb is on the screen, or maybe it's me now, I can't see. Deb is a distributor of our software in the USA and does a magnificent job. In fact, there's not many mornings I wake up and I don't have at least 2 messages on my phone from Deb and 1 email. So yeah, we keep in regular contact.
Yeah,
And,
so Ron and I are working together with ProRad, and yep, if you're in the States, I'm your gal. And like Ron, I'm also a radiation therapist and a medical dosimetrist, but 1,000 years ago, I was a radiologic technologist as well as a clinical coordinator and taught in a school as well.
If I may just do a quick marketing, if you want to go to proradvr.com, you will see our new website.
It's beautiful.
Thanks, Ron. Thanks, Deb.
Yeah,
Look,
and
so,
then I'll do mine real quick. XRT Solutions, xrt-solutions.com, and I've got all of that as well. So Ron's ProRad is a beautiful site.
Great, thanks. So I'm gonna share the videos that I recorded yesterday. Now, like I said earlier, a bit of a disclaimer, I did these by myself. We've had a variety of illnesses and pathologies across the office this week. And I work with the most magnificent team. And I don't know if anyone's ever seen those sort of 8-minute videos that we put out on LinkedIn and YouTube every few weeks. Well, Manuel records them. He does a magnificent job. I will reluctantly go in and sit in front of the tripods and talk about various things that cross my mind. And he will edit out most of the swearing and make them all look fantastic. And then he puts them online. And unfortunately, poor Manuel he hurt his back. I hope you don't mind me saying this. He hurt his back quite badly and was sort of not able to do not able to help me with the video as much as I wanted to yesterday. So they're all off center and bad. But when I talk through them, hopefully they'll make a bit of sense. So I've got 2 to show you. The first is what I would call the practice side, and this is where people can kind of go in and learn about things. In fact, one of the universities we work with in Ireland, they have a specific task that they get their students to do, both the medical students and the radiography students, and they say, okay, I want you to go in and set up the room how you think the cath lab or the IR room should be set up. And that is a bit of a task in itself. Are you putting the people in the right place? Are you putting the shields in the right place, et cetera, et cetera? So I'm going to try and share the right screen. And can anyone see a logo? Great.
Yes.
Yep. I'm actually quite proud of myself. Okay, so this is me, and you can see it's all off center, okay? So this is me entering the virtual reality room. I can't remember which one I chose. It's a little bit jerky because I'm just doing it quite quickly. And when you record VR from a headset, it can look a bit jerky. So you can see there, I've got everyone standing in an unusual position, and I'm setting things up. I didn't remember it being quite so jerky as this. So I've got posters on the wall. The first thing I do is I go over and get my radiation safety glasses. And you can see here, this is the dosimetry for the circulating nurse, and we've got 3 dosimeters on everybody. We've got one on their eye, one on their chest, and one on their pelvis. So we've got a patient on the table, and like I talked about, the surgical trolley going around. Move the radiographer. He's a big, intimidating guy. I move him down by the end of the trolley, the end of the bed. So there's a little bit of time, and I'm going to put a shield in front of him. The radiologist, she goes somewhere else in the room. Okay, so Manny's just given me some feedback that it's coming through very jerky. Sorry about that. I'll try and speak a bit more. So I'm turning the radiation on here now. You can see I've got a little menu. I can change my patient size. I can put them in any position I want to. And I've just turned the radiation on. And I've got different visualizations I can look at. And immediately you can start to see I'm at the back wall now, and I'm looking at the 3 doses per person. So I'm the user, and I've just taken my glasses off, and you can see how accurate it is, because as soon as I took my glasses off, my yellow or orange dose, which is my eye dose, immediately increases. Now, because it wasn't very long ago, I can remember what I did, and a bit later in the environment, I go and I pick my other pair of glasses up, and if I go back to the screen, which I think I do, I can see that eye dose drop down again. There's different ways you can look at the radiation. I like this one. It's where everything else is black and white, and you get to see the radiation on people. It's set up just like a real environment. So for example, I got an obstruction there because there was something in the way of the tube. So it won't let you drive the tube into someone. And I've just gone into a biplanar position, and you can see the radiation doses here are much higher, represented by the colors. And if I was to go back to the screens, they would have immediately have all jumped. I've also got a dosimeter on my wrist, which I look at every now and then to see what my live dose is in that area. And if I move that shield away from the nurse there, I can see that she's or he's been protected by a lot of radiation by the shield, and then I've moved it, and they don't get the protection that they should have done. Now, if I'm a radiographer, I'll know, or a cardiologist or a radiologist, I'll know what positions to put these tubes into, but we've also got some presets for the people who don't work in there all the time, and they are the most common presets per operation. We show neurology, hepatology, and cardiology. So there's some different environments. And you can also turn off the colors and see if you actually have learned anything at the end. So this is kind of an environment where you could say, well, I want to have the colors on, and then click through and go into an environment where I get to see what radiation dose I'm getting, if I've learned anything compared to I was a couple of minutes ago. But what I'm going to do now is I'm going to show you the second of these videos, the simulation side of the lessons. So so this one, you start off in a slightly different environment. You start off in a sort of a scrub room, and then to get into the theater, we just teach you a little bit about how to use the controls. So you have to put a pin number in a door and then open the door. And then big difference here is if I go back just a second, I'm asked by the instructions to stand in one place. So this entire set of lessons is the user or the student standing in one place, and then there are 2 things per lesson, and so you can see good practice and bad practice. So I think the first one was just talking about radiation safety glasses, and you can see I've moved actually deliberately that time off the circle, so I have to repeat that part of the lesson. So we're actually comparing like with like. And you can see as soon as the radiation is in progress, I can see that we record it for 5 seconds at a time. I can then have a look around the room. I can see where the radiation is going. And then we multiply those 5 seconds so that we get 15 minutes of screening per 5 seconds, so you can actually see what a real radiation environment would be like. So my glasses are back on now at all times in this room, except for the lesson. Without the glasses, we're wearing glasses. So this is a PA environment. And then the tube changes to a left lateral position. So this is the thing where a lot of our users kind of get a little bit surprised, because they're like, oh, suddenly they're in a much higher environment. You can see the radiation there on my hand. And to show them immediately what the difference is, we go straight into a right lateral environment. Now, if you're doing this in the desktop area, you can you get another little dosimeter on the or patient view on the wall, where you get to see the eye dose, the chest dose, and the pelvis dose, because you can't look at your wrist all the time. So this one's about the collimation. It was really good that you can see the tiny amount of collimation I've got there. It was really good that all three of the speakers today talk about things like laterals, collimation, frame rate, and the distance between the object image distance, because these are important lessons that we've got in the environment. So this is with a lead protection screen. You can just about see it in front of me there. And you can see the color of my hand. If I'd looked down just a little bit more in virtual reality, you would have been able to see the dose on my wrist, but I didn't. And then I've now got no shield, and you can see the huge difference in color on my hand. But I'll get all of this in my report in just a minute. So this is changing the size of the patient. One of the things that I didn't really mention today was how we've got all of these things to be aware of, but actually if you've got a larger patient on the table or a smaller patient on the table, that's one of the things we've got to be aware of too. And as patients are generally getting bigger as time goes by, this is something we need to be more aware of. So this one's the high dose rate, I think. So we talked about flat panel detector position. This is nice and close the way it should be. Again, I'll be able to show you in the report. So the dose there, I don't actually see, it was something like 78 microsieverts. And then we've gone to a maximum height. And hopefully I look at my wrist again to see what right. So I'm going to stop sharing that for just a second. Does anyone want to ask any questions about what I just showed them for a minute? Or can I show you an example of the report that you might get? And I'm happy to do both. Everything's followed up with a report. So Jason, you brilliantly mentioned data earlier, and that's all about that. Because if you don't know what you're doing, you can't fix it and you can't improve on it. Okay, so I'm going to share this screen now. And what we do is we always give a top-down approach for this. So this is my first lesson. And now the two rooms here from the top down won't look any different, but the radiation dose does. So I have no glasses on. Sorry, I have my radiation safety glasses on in the first part of the lesson, and I don't in the second. And you can see there's the difference of 1005%. So this is what I was sort of saying. This is a really quick way of showing someone this is massively important. And again, we go into the, So this is the left lateral position. And again, it's one of those things that with a quick flash of color like this, you can really see that this side of the room is getting a much higher dose rate. Now, we have all of the numerical data here as well, but when you go straight into the other side and the images change, you'll see now that I've stayed in the same place, remember, but the radiation is mainly on the other side of the room. So people look at this, like I said, they go through it once or twice and they're like, oh, I've really got this sorted in my head now. The collimation, again, that's something that's really important. So we go through a small collimation field, and the difference to your eyes is 263% or 300% to your pelvis or something. So this is quite easy teaching when you can show someone the dramatic differences. Radiation protection screens, again, look at that, nearly a 2000% difference to your eyes. So this is, and I keep saying it, this is something you have to talk to them about once, because they're just like, oh, I didn't like using them because it just sort of slowed me down by 15 seconds during the operation. You're like, yeah, well, if you could say to any other surgeon, add 15 seconds to your theater time and you will get, higher success rates or, more protection, they would jump at it. Different body mass. It's obviously not as dramatic, but you can still see there your eyes, which we mainly focus on, are getting 158% difference in radiation. What one's this? This is the changing the dose rate. This is massive. We're into the thousands of percent again. Flat panel detector position, lower again, but this one adds detail. This one is a change in the radiation dose, so it's an important thing to do. And that's all. That's the only lessons. And those 8 lessons, we think, cover everything that you need to offer in a radiation safety environment. Now, as a radiographer, you will learn a lot of extra stuff. But this is when they go to theater, it's like, do you remember the intricate positions and what to do? And, are you letting it slip after a few years? So hopefully you thought that was an interesting way of teaching and learning radiation safety. We've spent a lot of time developing it, and we kind of think it's cool and a little bit proud. There was some questions popping through. Does anyone want to re-ask them? Because I haven't been able to keep an eye on them. I know we did occasionally pop back and say, does anyone want to sort of, if we open the floor, but we've got about 10 minutes left. We don't have to use it. I taught for 10 years. I never made people stay until the end of the class before I would let them go. Like if we're done, we're done. But if anyone wants to ask questions, we've got some very knowledgeable people in here. Feel free.
Hi, it's Ron again here.
Look, unless anyone's got anything else to say, I'd like to sort of close up by thanking the 3 speakers we had, Jason, Shauna, and Dana. They were absolutely excellent. They made this webinar. I have a fantastic team around me. I sometimes call them my minders because they point me in the right direction and they make all of this sort of work. I have some fantastic colleagues who, create the software, design the software, test it to make sure. Like New Zealand is in nobody's time zone, so whenever we send anything to you, it has to be accurate and working 100%. And that's like a purely selfish thing. We don't want phone calls at 3 o'clock in the morning saying we're just about to start a class and it's not working. So what we do is we have a very thorough testing process so that by the time I press yes, it's all good to go. So thank you very much. We hope to see you again. We'll probably try and do these every now and then, because it's been a real pleasure putting together.
For better education.